eager to get started. We have a lot of health and social care rock stars in the audience and virtually, and I'm very happy you're here, and I'm very pleased to introduce today's lecturers. Both of our lecturers are extraordinarily distinguished graduates of the University of Chicago, Robyn Golden of the Crown Family School and Bonnie Ewald of the Harris School. Their titles speak a great deal to their enormous distinction. Robyn is Chairperson, Department of Social Work, AVP, Social Work and Community Health, Assistant Professor of Medicine, Nursing and Psychiatry. Bonnie is Assistant Professor of Medicine, Nursing and Psychiatry. They're both at Rush University. But rather than discussing their titles and achievements today, I would like to briefly describe what they're doing, in part because their mission aligns so closely with the mission of the Center for Health Administration Studies. Robyn and Bonnie, in collaboration with other colleagues, launched the Center for Health and Social Care Integration, dedicated to 5 goals: social work practice innovation, research and evaluation, policy development and advocacy, training and education, and communication about health and social integration. To advance this work, they've engaged a distinguished national group of social work practitioners, policymakers, researchers, the Coalition for Social Work and Health. They've convened this group to engage in and give visibility to the work that they're doing. Now, much of this work, I should note, has been inspired in part by many things, but in part by a National Academy panel that Robyn worked on and helped to organize, she participated in, that resulted in a National Academy of Science consensus report in 2019. Just a few words about the fundamental aspirations and goals of the center. The center really has emerged in the recognition of 3 things. The recognition that social risk factors, often referred to as social determinants of health, are deeply linked to health and well-being. 2, that expanded access to social care has a demonstrated positive impact on health outcomes. And 3, that social workers are specialists and experts in providing social care. It's no exaggeration to say that their work is having a demonstrable impact on the organization and financing of social work services and integration of health and social care. And I am delighted today that they will speak to us on paying for social care, investing in what matters. Please welcome them.
Thank you, as I still refer to you as Dean Jean. Thank you so much. And thank you, Keith, and thank you, Chaz, for having Bonnie and I back to campus. We're thrilled that the day turned out to be a nice one. So I want to just set us a little, and Jean, thank you for that introduction. But I want to talk a little bit about the imperative. We are thrilled to have the opportunity to talk about social care and investing in social care. More than 60 million Americans experience devastating 1-2 punches to their health. They have inadequate access to basic human care, healthcare, while also enduring the effects of discrimination, poverty, and dangerous environments that accelerate higher rates of illness. This came from the grand challenges, which Jean and Keith and I just spoke about, the grand challenges for social work. We have quite the imperative in front of us. We have the aging baby boomers, increasing rates of chronic conditions across ages, and many social and system factors that make it hard to meet people's needs and improve health. Health inequities persist. People experiencing inadequate access to basic care and resources while also experiencing systemic racism play out through discrimination, poverty, and dangerous environments that accelerate illness. The range of circumstances that people face and that influence their health have been shaped by a pretty brutal history. This history is baked into our current laws and institutions, and we need to address this reality head-on if we want to change it. So when the United States is compared against peer countries like France and Canada, it does not come out well. It comes out the very worst in terms of how we're performing in terms of health outcomes. On the top of this, you can see a number of countries with their own column, with the US in the right-hand column. Then you see multiple rows, different types of measures, quality, access, efficiency, equity, and healthy lives. And you can see very clearly that we are the worst. This came from a Commonwealth Fund report, which looks at how the United States stacks up against other countries on things like access to physicians, quality of care. It pulls from 3 separate surveys, which included not only consumers of sicker folks and who are healthy folks, but also providers. And basically it captures the experience of the medical system from the people who use it a lot, which is important to that we're always listening to our consumers and the physicians treating them, and still things don't look so hot, as you can see. Well, maybe this is connected to why things don't look so hot and maybe correlated to our low outcomes, that the US spends more on more medical traditional care and less on social care than any other countries. Social care, as we're defining, are the services that address health-related social risk factors and social needs into clinical practice. In 2019, the US spent 16.7% of our GDP on healthcare and 15.6% on social care. It's kind of the blue versus the green, compared with 10.7% on healthcare and 19.8% on social care in comparable countries. As you can see, I'm sorry, that's the blue. So we are spending more on more medical care, less on social care than anybody. Yet our analysis reinforces that our life expectancy seems to be shorter than most of all those other countries. So again, it really reinforces where are we with social care and why this is such an important discussion today. And such an important, Chaz was so instrumental in some of this work with us early on, so we're so excited to be partnering in this way. As social workers have recognized, and healthcare in general is increasingly acknowledging, much of what shapes our health is outside the realm of clinical or traditional medical care. Defined by the World Health Organization in 2017, as the conditions in which social determinants are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. SDOH, as we call them, are inextricably linked to access, delivery, and outcomes of healthcare. This graphic, based on nationwide community health data, county health data, is a model out of University of Wisconsin, shows that just how much social determinants impact the outcomes of care, with social and economic factors, the physical environment, and health behaviors estimated to impact 80% of an individual's health outcomes. These are all very intertwined. And what's so critical about this is that the bottom line is health is more than the absence of disease. And I think this really reinforces that. And this has been, if you will, a paradigm shift. For some of us who've been involved in looking at the person and their environment, which most of us who are social work related have done for years, this is nothing new, but it seems to be new in a lot of other arenas, which is exciting, a little frustrating sometimes because social work doesn't quite get acknowledged as having this history, but we're trying to bring that back to the fore. But the other folks kind of feel like they've discovered it in a new way. Physicians, nurses, not to bash our interprofessional colleagues by any way, shape, or form, but it's, sometimes it's hard not to say everything new is, been here or old again. So everything old is new again, I guess. So just to talk about some other factors, social determinants of health are not only intertwined with outcomes, at the community level, but when individuals report them as specific concerns within the context of the healthcare interaction, we see these individual needs also correlated with adverse health outcomes. There's plenty of evidence around that the importance of these health-related social needs, you all know this already again, but not everyone does, that we know that psychosocial challenges such as social isolation can increase stress and displace the focus and energy from attending to medical conditions. Adherence to medical care may become secondary to needs perceived as more urgent for survival, such as keeping heat on in the winter by paying utilities. On top of that, the literature shows that one's socioeconomic status and physical environment, such as unsafe housing, inadequate public transportation, can lead to higher use of emergency departments and other acute care, and to worse outcomes in terms of chronic conditions and life expectancy. I've been on emails all weekend about the fact that our asylees, we're doing a lot of work at Rush with our asylee population, and I don't know if you saw, but the police departments are full and there's nowhere for a lot of people to go. And of course, they are being sent to the emergency rooms as shelter, which is very complicated in terms of, is that the best use of an emergency room's resource? But what do people do and where do people go? And believe it or not, it's still warm out. So what's going to happen in a few weeks? We also know that the impact of these factors, such as access to employment and safe housing, accumulate influence health outcomes over a lifespan, more so than genetics do, resulting in inequitable outcomes in health. The unfair and avoidable differences in health status that are so prevalent in our city and our country. So it's hard to talk about social care without talking about health equity. Something we look at a lot is what we call the death gap. And we look at a map that goes from, in Chicago, not everyone on the Zoom is probably from Chicago, but we look at life expectancy that goes from downtown Chicago all the way to Oak Park. And it really reduces by, believe it or not, 12 years when we get from West Garfield Park from downtown, 85 to 60, 73 now, it went up 12 years. Anyway, and then it goes back up to 85 when we hit Oak Park. No surprise. For those of you who are on the phone, that's our first wealthier suburb to the west. So, social determinants of health have taken center stage in recent health policy discussions because of the growing focus on global payment, accountable care organizations, and other initiatives focused on improving population health. Our payers are noticing our healthcare costs are high, the outcomes are poor, so they've been wise enough to think, well, maybe it's social circumstances, social risk factors. So healthcare providers are increasingly being asked to measure impact in terms of health outcomes of the populations they serve. Given that medical care influences a relatively small portion of overall health, as I just showed you, these value-based financing models that Bonnie will get into a little more face substantial challenges in equipping healthcare providers to achieve improvements in the population's health. The increasing recognition by health providers and policymakers of the importance of social determinants is promising. Acknowledging that health outcomes are heavily influenced by factors beyond the four walls of the hospital, beyond the four walls of the physician office, is a pretty exciting one. Yet, health and social care delivery systems are not currently collaboratively addressing health-related social needs at scale. Why? Well, maybe some of us feel like part of it is that there hasn't been an absolute clear financial incentive due to the difficulty in quantifying the return on investment with this kind of spending. So we can talk about that a little more in the Q&A, but I left you with a little provocative piece there. Research is increasingly showing that not only do health-related social needs influence outcomes, but also that when we invest in activities to address those needs and to integrate care, we do see payoffs in terms of improvements in outcomes and in cost prevention and reduction. A study you may have seen before by Laura Taylor and colleagues review findings describing 39 articles regarding the health and financial impact of investments in social services or integrated models. Of these, 82% reported some significant positive effects on either health outcomes or healthcare costs or both. The literature indicated that most positive impacts on health improvement in healthcare spending reductions were evident in interventions relating to housing support, income support, food insecurity, and care coordination. So what I say very often, it's not enough for us to just screen for social determinants of health, but how are we going to address the identified needs? One cannot go with the other. Otherwise, we're setting people up for, again, falling through the cracks and not addressing their needs if we're screening and saying, you have this issue, but we don't have a way to help you with this issue. So it has to go hand in glove with hopefully some investment in the basic needs that people have, which are typically housing, transportation, food. As all of this work, it is critical that we be person-centered and try to understand people's own priorities overall and priorities in relation to accessing care. The National Age-Friendly Health Systems Movement calls out the importance of being attentive to what matters most to patients. When we do that, we tend to see things like what Institute for Healthcare Improvement talks about, articulated recently. We want, what they hear from their patients in many surveys is, we want to be comfortable, we don't want to be in pain, we want to be close to family and to spend time on things that give us joy. We want the benefits of medical treatment, but we want to avoid the burdens if possible. And for those of us who work, oh, I'm sorry. Oh, I didn't know it was one of those. But see, this is what happens when you work with younger people. Sorry, Debbie. Thanks, Bon. So what we see, and critically calls out that we truly take a person-centered approach to improve the quality of care while also improving the quality of life. Know that this person-centered approach of understanding what matters most to people paired with person-centered care with an interprofessional team is what is needed to achieve health equity, as we will hopefully know it someday. So I want to just let's look back as we think about how we can move forward to expand access to comprehensive and social care. In 2000, and I'm sure some of you in this room were involved in this work, Medicare pilots were a big deal. But during the 90s and the 2000s, CMS, Center for Medicare and Medicaid, launched a national case management payment methodology based on successful pilots with case management, with nurses calling assigned individuals to provide case management. As this quote summarizes, large firms quickly developed providing case management, but largely failed to deliver on quality and cost goals, and the program was essentially discontinued. Follow-up analysis showed that the programs that did succeed had one key element in common. First name, caring personal relationships in which the case manager was an advisory friend who got to know the person and made a personal connection. However, the majority of systems use models where the nurses called had no personal connection to the individual, and that the calls were often characterized by patients as harassment, which was opposite the goal. As IHI called out in 2011 in a white paper, these findings are critical for us to keep in mind as we think about social care, care coordination, interventions in general. It's incumbent upon us to center the patient's experience and priorities in order to be effective. So relationship matters. Nobody in this room is surprised by that. But how do we pay for relationship? It does pay off, but how do we invest in those kinds of relationships to make the difference that so many people are saying that is needed? Around the time we were part of a group with the New York Academy of Medicine, the Social Work Leadership Institute, to convene discussions about how to more effectively meet people's needs across the types of care. And particularly this was an aging focus back then, and many of us were very much focused on chronic conditions and functional limitations and looking at that in terms of care coordination. These discussions led us to creating the National Coalition on Care Coordination, which is active in DC to raise the profile of care coordination among policymakers. This happened at one time because this group first went in saying, let's get social work paid for, and had some pushback, particularly when they were meeting with CMS and other folks on the Hill, and people were saying, well, but what do social workers do? We don't care about the discipline. So we framed what we were doing as care coordination, which is not off, but what we were doing was social work and good social work. So we had to use that that name for a while, care coordination, and still do to some degree. And so kind of working on both tracks was the way we've kind of looked at this. One of the early reports we commissioned reviewed the needs around chronic care, identifying that this requires linkage between medical care and support services, as well as that interprofessional team members to address a person's unique needs. This laid, of course, the groundwork for social work. Then in 2011, and I think repeated again in 2017, Robert Wood Johnson Foundation surveyed 1,000 primary care physicians about the importance of interprofessional teams was reinforced through that study. It didn't go in with that notion, but what that study showed was that 4 in 5 reported that they did not feel confident in their capacity to meet their patients' social needs, which impedes their ability to provide quality care. They weren't aware of the social services available or complicated eligibility criteria they were confused by. So they were a little worried at times to even ask the questions what some of these needs were because they thought it would open a Pandora's box for them. 85% of primary care docs surveyed believe that unmet social needs, things like access to nutrition, transportation, housing, are leading directly to worse health for all Americans. So they believed it. And if they had the power to write prescriptions to address social needs, such prescriptions would represent approximately 1 out of every 7 prescriptions they write. And this was back in 2017. And that's huge when you think about it. This is part of the evolution and part of the excitement that we've been part of. In 2013, then, some of us were involved in a health affairs study that following that a group of us through the coalition, finding that we could lead to lower healthcare use and costs with social care interventions. And so we really started moving from screening to more interventions, and how do we invest in that need? And this study called for, or this article called for continuing to develop and refine models that are credible, replicable, and sustainable by researching the professional skills and knowledge, the activities, tasks, and services, and all combined with the patient risk factors that we can most impact with social support. So it was really calling for a deeper dive into what we've been trying to do. And then in 2019, we were involved with the National Academies report, as Jean mentioned, pretty exciting. We raised the flag really high to get the National Academies to look at a report just for social work. They had done one report on nursing, and we were excited by that report and thought, how can we have a report about social work? So we went down that path. And what ended up happening was in the 11th hour, they said, oh, the National Academy really doesn't do reports on discipline-specific kinds of things, even though they had finished the nursing report 6 years earlier, and we had heard a buzz that there was a new report to redo that nursing report already in the works. So here they booted social work out. They wanted to reframe it as social care. And, ultimately, we still got the attention, and maybe it was broadened to social care, but we tried to make the best of it, even though we were a bit frustrated. But the report was to help answer about who and when we should, as a national coalition who started this report and this work, who should be involved and when we should be involved as social care professionals. We secured funding from over 70 institutions, including UChicago, the Crown School, as well as Chaz, along with several local foundations. And this study, it was kind of amazing. It was the easiest fundraising I've ever been involved in because people really were committed to this. And I was lucky to be, lucky to be one of the 3 social workers on the panel. It was tough, though, too. There was a lot of challenges from the other disciplines on the committee, mostly physicians who were saying, you know, why social work? Why is social work part of social care? What have you done? Show us your evidence, that sort of thing. And we tried to accumulate the evidence and show, but it was still, you know, a tough sell at times. And so the bottom line is, how can services that address social needs be integrated into clinical care? That was the overall work that went on for 18 months, and I think some great outcomes did occur. Unfortunately, the report did come out right before COVID, so we took some of it on the road, but you know, we're still taking it on the road by talking about it here. So what the report talked about was that 2 helpful ways that the report helped the field by honing definitions. We talked about health-related social needs being within the context of a patient reporting a concern. We know, of course, that there are social determinants of health that might be harmful to a patient's current or future health, even if they don't name it directly. The report suggested we call these social risk factors. The committee recognized that there were a number of ways that healthcare delivery systems can make a difference on these issues broadly, and define social care generally as activities that address social needs and/or social risk factors. We then outlined 5 complementary activities that facilitate the integration of social care into healthcare: awareness of these social risks and social needs, adjustment to clinical care, assistance to address needs, and alignment with community partners. And then last but not least, the final A that so many of us are connected to is advocacy, to minimize the social risk and increase social care resources. So we can get into that more later, but an example is transportation. So an example of awareness would be asking patients if they have a way to get to their appointments. Believe it or not, it's the major issue as to why people no-show, as they say. Also asking them about, can they get to the grocery store? Those sorts of things, of course, have an underlying impact on health. And alignment had to do with, can we reduce the need for in-person healthcare appointments by using other options such as telehealth appointments? This was, of course, before COVID, which now they become normative. Assistance had to do with, would we be providing transportation vouchers or coordinate rides so that patients can travel to healthcare appointments? Alignment would be investing in community ride sharing or time bank programs where volunteers could get together and help each other get to appointments or grocery store, you name it. And advocacy, of course, would be promoting policies that fundamentally change the transportation infrastructure within the community, or ensuring transportation benefits as available to uninsured individuals. What some of us liked about the 5 A's is it really integrates the micro and macro so well. So to use the 5 A's just a little more in depth, that the activities, and we turn to think about the resources needed and types of investment it takes to this work to be carried out. We need a workforce, an interprofessional one that ideally cross-sector, available to conduct screenings and to address needs and coordinate care. We need training and support. We need tech infrastructure such as adjustments. The interoperability aspect of this is critical. Our community-based organizations who could be involved in meeting some of these social needs and who are involved have no way to talk to the hospital, and vice versa. We need to invest in community partnership development, not just assuming that community-based organizations, social service agencies who can barely keep the lights on can deal with all this without giving them support to deal with it. And those are the people who are on the ground and really know what the residents of the community need most too. And we need to have the time and resources it takes to influence public perception and ultimately public policy around issues such as investment in healthcare services and workforce, investment in housing policies that help build intergenerational wealth, and the list could go on and on. So the report really did get into talking about who is the social care workforce, and it's nice to know that we did come out on top with larger font and everything, that social workers were recognized as specialists in providing social care. That was a battle, but we came out well. And then we included other other groups, community health workers, which is a growing group that Bonnie will talk about, navigators, nurses, home health aides, even lawyers came out very clearly. Our committee also recognizes there are significant systemic issues to address in order for this transformation to happen at a large scale in an effective, sustainable way, and that expanding healthcare beyond traditional medical settings will require health system administrators, practitioners, researchers, and policymakers to expand their emphasis on healthcare delivery to include social care, the services that address these risks. As many of us experience in our day-to-day, there are barriers to this. And part of it is our dominant medical model system. It's not designed around social care provision. We'll talk more about that. And that we need to embrace care models that have greater integration of both. And we need for those cross-sector partnerships. In terms of workforce concerns, as we see across healthcare industry, the recruitment and retention in social work and other roles doing this work is a concern, especially since so many of these positions are grant funded, and when the money goes away, the positions go away. So how do we do that? How do we make sure that everybody's staying in their swim lane, yet working as a team, reducing that competition, all of that? And then there's the financing challenges, which Bonnie will go into, and the answers around that. Just to end my part, in a recent health affairs, Laura Gottlieb, who's a friend of us from UCSF, who runs the Siren program there, she talked about the collective aspiration is that social care standards and incentives will help advance better health through more robust engagement by payers, redefining the scope of hospital services, delivery systems that are better equipped to support social care effectively, and more dollars to flow to CBOs and social services. This will absolutely enable population health change and what we should truly aspire to. And then in 2022, just to talk about a New England Journal of Medicine Catalyst report, a high percentage of clinicians and administrators in hospitals in healthcare settings say that patient health has been improved by SDOH, social determinant initiatives in their organizations. So on that note, Bonnie's going to tell us how that can happen. And we need these investments on how we can better make them. So thank you.
Hi, everyone. Wonderful to be here this afternoon. Thank you, Robyn. Oh, we'll need that. All right. Thank you, Robyn, for talking us through the imperative and our framework for the types of activities we're talking about trying to get investment in. I'd like to first start by just naming what are some of the typical funding sources for some of these diverse social care activities. We have grant funding, healthcare funding, governmental funding. So just to start at the top, governmental funding, this could include like SNAP funding, for instance, home delivered meals through the Older Americans Act. We have state funded initiatives like in Illinois' Choices for Care program that embeds care coordinators in hospitals to support folks as they go home from the hospital. Public health initiatives, we've seen a lot of public health dollars in the last few years be leveraged through a really, in an intentional way to not just do contact tracing, et cetera, but to help address social needs so people could isolate, et cetera, if they had COVID or were exposed. There's been federal and state funded demonstration projects. I'll talk about a few of the things on the Medicare and Medicaid innovation side, but we've had demonstration projects, like one we were involved in was through HUD, for instance, Housing and Urban Development, looking at supporting resource coordinators based in housing sites. So kind of these, a number of different ways that the government is funding existing kind of social care resources and also the workforce providing some of these services. Also, of course, grant funding. This is one of the major sources. That's why it came up on the screen first, a mix of philanthropic funds, individual donors, and then some of the governmental funds are grants technically instead of contracts. And then there's the whole realm of healthcare financing, where we hear often, we saw in the chart that Robyn showed, that nearly a fifth of our country's GDP is spent on healthcare dollars. most of this is, it's through healthcare insurers. There's mechanisms I'll talk about a little bit, kind of the historic model of billing fee for service, but increasingly moving towards other kind of reimbursement models. And then ways of thinking about leveraging hospital operational dollars, for instance, to maybe try to make an impact at a broader level beyond the individual patient intervention, and a lot of alignment opportunities there. However, we know that that in the current state, that good intentions by clinicians, systems, all of us in our daily work are really stymied by payment restrictions and the outright lack of direct payment for social interventions. So to make this work in the real world, most of us are pulling together support from various types of sources to support actual social care activities. This, of course, makes it so that we need to be coordinating funds with different timelines, different kind of reliability in terms of knowing upfront how much you might be getting versus waiting for certain numbers of referrals to come through. It makes it so that we need to track sources with kind of different deliverables and different timelines. So there's challenges there, but of course we all know how important it is to kind of diversify our investment portfolios. So for that same reason, this kind of braiding and blending funding approaches are often used. Folks might have heard those terms before. I'm just going to put two images up just to communicate what we generally mean by braiding and blending, but it's just two different ideas of taking multiple funding sources coming in, and with braiding, the idea is that you're still tracking, okay, I have this revenue source A that's supporting this concrete resource for this patient population, revenue source B supporting this concrete resource that allows us to do this advocacy work, but continuing to track those the revenue and the outcomes at the individual level. So that's kind of this concept of braiding, and then blending is this concept of kind of pooling the funds and pooling the outcomes that you're collectively working towards, and having all of the original funders on board with that, and all kind of transparent arrangements. So I just wanted to mention that a lot of our organizations on the ground are actively doing this to make our programs run. The National Academies report that Robyn was talking through the social care activity framework from, they did recommend, based on all the research, the live testimony and input from the field, that CMS, the Centers for Medicare and Medicaid Services, and other groups really do pay more attention to financing of health and social care integration. I'm going to walk through some of their recommendations in the upcoming slides. But before doing that, I definitely want to say that we recognize that a lot of, in order to achieve health equity and to address a lot of the systemic and infrastructure gaps, and also core other challenges like systemic discrimination, we know that there's a lot more than just the kind of investments that we're talking about today. Today, we're kind of on this focus of health and social care integration, while we also are kind of keeping our feet to the fire on some of the broader systems change pieces, like transportation, affordable housing development in the first place, environmental justice initiatives, and making sure everyone can have access to the internet. Okay, so the National Academies report outlined kind of 5 focus areas. I'm going to talk through these one at a time. So the first one, update legal definitions of healthcare. And what they really are talking about here is looking within our current, they're focusing on Medicare and Medicaid, but within the current kind of reimbursement system, how do we look more broadly at what healthcare is to kind of expand that infrastructure? Dr. LaShawn McIver, the director of CMS's Office of Minority Health, said in a piece last fall, as the nation's largest health insurer, CMS has a critical role to play in driving the next decade of health equity for people who are underserved. Our unwavering commitment to advancing health equity will help foster a healthcare system that benefits all for generations to come. And I think this leadership from CMS on recognizing how they can be looking at CMS policy to better support Medicare and Medicaid beneficiaries today, that's really important. And what I like about this quote is it also calls out the systems change role that CMS plays, and commercial payers, other groups are looking at CMS for leadership. So what I'm about to talk through about some Medicare developments as one example is really exciting, not just because it'll open doors for current Medicare beneficiaries, but hopefully contribute to some of the broader healthcare culture change, and again, expanding this view of how we all think of healthcare. So just a quick to kind of share the grounding definition. Folks have probably heard of fee-for-service reimbursement, reimbursement structures. There's a lot more nuance we could go in here, and people in the audience could probably help me with that nuance. But at a high level, I just want to share that we typically in healthcare have reimbursed on this volume-based basis or fee-for-service. So you provide service A, you bill for it, the organization gets reimbursed, you provide service B, et cetera. So FFS, you'll see the acronym on some of my slides. So in order to get to a world where we can have some of our social care activities potentially be reimbursed through the fee-for-service mechanisms, we need codes or other ways to capture and describe what we do in a concrete way, and we need the insurance or the folks that might be paying for that to approve that. So those are kind of two of the important movements. There's various types of billing codes, approval processes. I'll be focusing mostly on what are called CPT codes, current procedural terminology codes that the AMA helps oversee in collaboration with CMS. So a couple slides on some Medicare developments. So first off, Medicare statute limits Medicare coverage to only being on items and services that are reasonable and necessary for the diagnosis or treatment of an illness or injury, which makes it hard if you're talking about diagnosis and treatment to kind of talk about the value of social care activities when there's certainly value on treatment. There's ways that social care helps with diagnosis, but we also know that probably the biggest impact of social care is on prevention in the first place. And we've seen through some kind of basically recent regulatory actions over the last couple of years under President Biden's leadership, kind of this more comprehensive view of looking at what are, given the statutory language, potential opportunities to have Medicare be a little bit more responsive. Supported by the Affordable Care Act and some other legislation, we've seen a lot of development on how Medicare fee-for-service has started to support the kinds of care that we're talking about today, from annual wellness visits to more monthly billable codes that actually reimburse primary care based and other teams to provide care coordination and behavioral health integration. Some of those billing codes that folks might be familiar with are chronic care management is the most common code set family that is really relevant here. Behavioral health integration, which has a number of different billing codes that are part of it, and could dig into all of these a little more in the conversation or in Q&A, as folks are interested. But one really kind of important thing just to highlight as the big picture here, in order to try to reinforce continuity of care and build on the primary care, relationship, the way that these are structured is that these codes are all billable by the physician or other qualified health provider, which typically is a physician's assistant, nurse practitioner, and there can be services provided as part of the healthcare team, which is really helpful. CMS, for instance, chronic care management, which I believe was first introduced in 2014, around then. From the beginning, CMS recognized, going back to that 2009 report that Robyn showed, the value of interprofessional team members. And so even though these codes are, the physicians and others are the kind of qualified health providers, from the beginning, they've recognized that other team members would likely be providing a lot of those chronic care management services, which is exciting to have that recognition. Yet it's been very, very difficult operationally to grow the use of those codes in the field. I personally at Rush worked on it for several years, trying to make it happen at Rush. We have folks that are still working on it. There's challenges, and I think there's a lot of opportunities But things that we are very excited about, I think, are that CMS is recognizing that there's a good foundation with the chronic care management codes, et cetera, to build on to support this team-based work. And as CMS in that quote earlier emphasized, they're really looking at how do we make Medicare and Medicaid work better for everyone. And as part of that, they recognized an opportunity to have more Medicare recognition of services, some of these wraparound services. So actually just in this year's proposed what's called the physician fee schedule. So in July, CMS releases their proposed Medicare policy for the next calendar year. So in what we heard this July and is now being finalized, and we'll learn for sure in November, is that CMS is proposing to have a number of really, what I'm very excited about, positive changes on Medicare Part B side. So some of those are listed here. For the first time, they are going to recognize and reimburse for social determinants of health screening completed on the Part B side, just like they have in the past for depression screening, as another example. They are going to recognize and reimburse for community health integration services, which are, again, billed through the primary care provider typically, but explicitly recognize the value of having community health workers, patient care navigators. We advocated for them to recognize social work, non-clinical social workers in that camp as well, folks who are in care teams providing community health integration services across the country. So CMS proposed that, and they're, again, looking at how they're going to finalize that rule. Similarly, they also proposed principal illness navigation services, which kind of complement the community health integration codes and would support, if it's mostly focused if someone has one focus of care, one illness as a focus of care. So cancer care is one common setting that is, I'm on the National Navigation Roundtable through the American Cancer Society. And everyone was really, really excited about what this is going to mean about navigators across the country not having to only be reliant on grant funding or the Cancer Center coming up with some other way to support the team members. So really big deals if it does all get finalized in a similar way as to proposed. I also wanted to mention that CMS proposed recognizing a new set of codes for caregiver training services, and they recognize a number of different interprofessional providers as eligible to provide those services, such as speech therapists, occupational therapists. They neglected to list clinical social workers on that list, and we know that clinical social workers around the country, or including at the VA, are the main kind of caregiver interventionists. They certainly are at Rush, and they're key to our strategy. So we're hopeful that CMS will broaden that guidance a little bit so that those family of codes can be more fully useful to support the care teams that are happening on the ground. And the bottom bullet here is another thing that we're very, very excited about, is that for the first time, CMS is proposing to recognize clinical social workers as well as other mental health providers that are coming on board with Medicare to bill Medicare for a set of codes that are called the Health and Behavior Assessment and Intervention Codes. HBAI is an acronym that you might hear for those. HBAI codes reimburse for assessment and intervention of factors that affect how people engage in their healthcare and other factors that affect people's health. So there's a lot that social workers do that are perfect fits for HBAI codes. Historically, psychologists were the only folks that could bill for them. And social workers, there's some kind of complex policy barriers that have kept it hard to have made it so that CMS hasn't been able to recognize social workers in this way yet. So we're very excited to see that proposed for this year. And as I'll kind of close with today and share more details on, we're also working on a legislative route to fix one of the core policy barriers, because while it's very exciting that President Biden's administration is recognizing this, we also know that unless it's kind of codified in statute, it could shift in the future. Okay, so I'm going to shift to talk for a couple minutes about Medicaid, which of course is also very important on the social care side of things when we think about folks across the country who are lower income, that Medicaid is their main insurance source. States have a lot of different options when paying for social care. There's a lot of details on this slide. I'm not going to go into that many details on this, but hopefully they're a helpful reference in the future. Just want to mention that states go through regular kind of overall state plan negotiation and amendment processes with CMS as part of their kind of proposal of to serve everyone in our state, here's our plan. They also, as part of that, can propose to participate in different kind of unique or special opportunities, such as a health home initiative that was made available to states. They can apply for specific waivers to certain sections of their requirements. And so it's through some of those pathways that states are able to look at potential flexibilities. Folks might be familiar with Medicaid, that Medicaid covers long-term care. Medicare does not, but Medicaid does cover long-term care. And at this point, most, if not all, states have gone through what's called the 1915B waiver process to say, hey, we're glad Medicaid covers long-term care if people need a skilled nursing stay, for instance, but it would be great if we could leverage those same dollars and pay for people to stay in the community instead. And so CMS can then say yes and grant that waiver. So across the country, there are Medicaid home and community-based services available, typically leveraging the 1915B waiver process. I want to mention that because a lot of that stuff is what we think of when we think of social care, transportation, folks coming into the home to help you with your laundry, supported employment supports, those kinds of things. Another things we're seeing around the country moves towards Medicaid managed care. Again, I think it's over 40 states at this point have managed care arrangements. In Illinois, the majority, I can't remember the numbers offhand, but certainly the majority of folks in our state are being moved essentially over to managed care arrangements. There's a lot of oversight, et cetera, that is important for us to have in those arrangements. And it also opens the door for some opportunities with what's called in lieu of services, which is a similar kind of idea of saying, hey, instead of paying for X cost that is in kind of Medicaid requirements to cover, we would like to propose to cover this in like this way instead, and it's going to cost about the same amount of money. So the in lieu of services mechanism is kind of the state's official way to say, here's what we would like to do instead of this, and here's why we think this will be a good substitution. Just last year, CMS released guidance saying that states could use this in lieu of services mechanism to not just be an immediate substitute, but to try to prevent. So there's a lot of examples we could think of, but to say, okay, we want to work on helping address mold infestation. So we're going to use a pathway for in lieu of services to prevent some future procedure that might be related to asthma. I'm not familiar enough with the healthcare needs. But instead of that procedure, we're going to propose to CMS to have an in lieu of approach and be able to actually pay for someone to come remove mold. So that's one mechanism through the Medicaid waivers, or through the managed care, excuse me. And then last, the 1115 waiver is a broader waiver that's very relevant that a lot of states, including Illinois, have leveraged. And CMS has recently said that they're really looking there at housing, nutrition, and case management for health-related social needs as their main priorities. Okay, so to keep moving through a little bit here, I'm looking at time and aware, I want to get through a few more pieces. Medicaid really just is, for the broader reasons of how CMS is a broader leader in this work, Medicaid is a really important kind of data source and kind of compilation of demonstrations to look at, because there really are 50 plus with DC and Puerto Rico systems that are all trying things in similarly but slightly different ways. We also see a lot of leadership at the state level, like on the community health worker side, for instance. We see 29 states are currently have pathway to have some reimbursement for community health worker services, a mix of through managed care organizations, some it's actually built into the state plan amendment. Illinois, if folks are tracking what we're working on here at all, or we're in process of this, of first getting a formalized certification and then with the plan to build it into our state plan. So a lot of development and momentum kind of there at the, driven by Medicaid. And also we're seeing, as I showed a couple of slides earlier on Medicare, learning from the state's innovation in Medicaid, leveraging CHWs, and how Medicare is looking at that. So it's just a lot of momentum. I'm going to move us through and now touch on the second overall area of recommendation from the National Academies was to reform healthcare payment overall, and this is looking at alternative payment models. So we know, of course, that social care aligns with value-based care incentives, promoting health overall, preventing exacerbation of conditions that might have been made not quite as worse if folks had what they needed in the first place. As some examples, social care also helps folks engage in care. Robyn talked about no-shows and appointment attendance as one example. We've data on reducing ED visits and preventing likelihood of folks coming back to the emergency or to the hospital itself. We are seeing investments in value from kind of value-based care arrangements in social care in limited areas. We're seeing pilots to send food home to people for 6 months if they have hypertension, and like that as one concrete example. We're seeing United Health Group invest in affordable housing more at the community level. Within Medicare Advantage, there's a lot of opportunities to have the Medicare Advantage plans be able to make available some kind of very defined concrete benefits. However, I think across the board, at least from what I've seen, it's been hard to, things haven't persisted in a way and become available to broader populations outside of kind of specific chronic conditions, et cetera. And it's really hard to pin down the exact outcome of any of our one activities, especially when we're trying to be person-centered, and especially when our activities have this blend of micro and macro, like Robyn talked about. Yet we're working in this world, and I think there's a lot of benefit and opportunity where CMS is pushing us to move more and more towards payment mechanisms where there is a little bit of risk or potential penalty or potential upside based on how we perform either on quality measures or on cost. This graph is pulling out from kind of CMS's latest description of what their target is, that in 2021, 44% of Medicare beneficiaries were covered by getting care at a primary care provider, or were on a plan where they where the providers had some kind of accountable care arrangement. CMS wants that to go from 44% to 100% by 2030. So that's a big shift. That's at the beneficiary level, but at the organization and provider level, that means they want every single provider to be kind of in these arrangements where there's some adjustment on what the provider is getting, essentially based on outcomes and quality measures. A lot more discussion that we could have there. The third area of recommendation is boosting accountability. So looking at classification procedure codes to describe services, we're seeing a lot of increasing attention to incentives and recommendations for healthcare to screen for social needs. CMS is requiring it now on the hospital side, soon to come on the outpatient side. NCQA, which does HEDIS measures, if folks are familiar with those measure sets that describe health plan quality and outcomes. NCQA has a new HEDIS measure. I'm sorry about the formatting transfer issues. Joint Commission is encouraging screening for representative sample of folks. So a lot of attention to an encouragement to healthcare to begin screening for needs, and attention to how can we capture that data in a consistent enough way so that we can communicate across systems and communicate in a way that we might, and research and communicate in a way that we might do so around health physical health conditions. So that's where this world of Z codes comes in. Folks might have heard about Z codes. They're a family of diagnostic codes on the ICD-10 diagnostic code side, and they just describe factors that influence health status and that influence contact with health services. So some examples of Z codes are, like one of the larger categories is problems related to employment and unemployment. There's a lot of specific ones under those, but you can imagine that as we collectively work on getting social care more integrated in healthcare, that kind of codifying how everyone is capturing needs, et cetera, would be helpful for alignment and research again. The Gravity Project is one nationwide initiative that was funded initially by the Robert Wood Johnson Foundation and with the Social Interventions Research and Evaluation Network out at UCSF that's leading a lot of this work. And I recommend folks check out their website if you are interested in learning more. The fourth kind of piece that I'll just briefly call out is that the National Academy's report named the importance of looking specifically at folks who are dually eligible for Medicare and Medicaid as we think about financing. There's a lot of development happening. There have been a lot of initiatives through the Innovation Center, a lot of building on Medicaid managed care that we already talked about to figure out how to best meet needs of folks who are Medicaid and Medicaid beneficiaries. One piece I want to call it specifically is PACE, the Program for All-Inclusive Care of the Elderly, which is generally around the country is supporting folks who are dually eligible, but providing the care all, for the most part, in one physical center or as one core coordinated team. And this care includes a lot of social care, including transportation, meals, adult day services, nutritional counseling, social support groups. So PACE is a wonderful model to learn more about. And in Illinois, we are just beginning to have PACE sites roll out in real action here, which is wonderful. Okay, last area of recommendation is to increase capacity, the administrative capacity of social service providers so that we can enable workflow or bidirectional workflow and communication across sectors. We know that community-based organizations are trusted leaders, in many cases, partnering with communities to understand their needs, address their needs. Community-based organizations are funded through networks to provide these services, so it doesn't make sense for healthcare to come in and just build on its own. We know that demand for community-based organization services is increasing as healthcare is increasing to identify needs, and unfortunately as the needs persist with the pandemic, et cetera. And we know that community-based organizations haven't traditionally been funded to have the infrastructure and kind of technological resources needed to keep up with all of these referrals, but also to, say, meet our the cybersecurity requirements that it takes to contract with a health system and to have to be considered what's called a covered entity, just as another example. There's challenges CBOs have with recruiting and retaining staff because of some of their funding sources. So lots of challenges, but also opportunities. We're seeing social health assistance referral platforms, Unite Us, now POW, that developed out of U Chicago, Find Help. They're like these online platforms that are sort of like Yelp in that they curate information about resource providers, but also have the ability to provide some reviews and direct referrals, which can be really helpful and can also be really challenging for the organizations that might be asked to be participating in a couple of these different platforms and not getting any additional funding to be able to do that. Nationally, luckily, we have the Partnership to Align Social Care that is working on some of these issues, that's bringing together leaders from across sectors, including payers and government, and with strong leadership from the community-based organization side to try to better align systems here. One structure that they're advancing is called community care hubs. And what community care hubs do is essentially make it easier for a healthcare entity, such as if I was at Rush making this decision, to contract with community groups and to have a facilitated process so that it's kind of one contract with an umbrella agency that organizes this whole hub of, say, 30 providers. And so it's a kind of a an organized, streamlined process so that I, as on the healthcare side, don't have to be creating 30 individual contracts and figuring out 30 different workflows for X and Y needs. So that's kind of the idea. And nationwide, we're seeing community care hubs really making a difference, not just at kind of patient level, but also at the geographic level when they are able to bring partners together. I will mention that the Administration on Community Living, ACL, which is under Health and Human Services, just funded a big center of excellence focused exclusively on this that's run by a nationwide group called US Aging. Okay, I'm going to just spend a few minutes talking about our social work campaign, and then we'll yeah, as Jean opened at the very beginning, talking about our Coalition for Social Work and Health, which has been a project that we've collaborated with Chaz and UChicago, but a number of social work leaders around the country on for several years. So why focus on social work? We know that there are many important disciplines to have at the table, and we are focusing on social work because we know that they're getting left out of the conversation, unfortunately, despite an ability to really continue making a big impact on health and health equity. We are in the midst right now of a national campaign to work on telling this story and trying to get more people on board. The language that you see on the slide right here is some language that many of us social workers and non-social workers alike have honed to try to have simple go-to phrases to say, social workers make an impact by skillfully supporting people today while working to build stronger systems of tomorrow. Social workers promote health. Social workers enhance hope. Social workers improve healthcare outcomes. We have a lot more talking points along with that, but that's just kind of to share a little bit of a taste of what we're trying to do to help broaden recognition of why social workers should be at the table. We also, I alluded earlier to the definitional, kind of one of the policy challenges that's we're trying to address. Social work services are defined in Social Security Act specifically as around mental health services. This was in order for social workers to get recognized as mental health providers, kind of how we had to get in, which was helpful to now have social work be one of the largest mental health professions. And now it's time to think about how to broaden that definition so it's not restrictive, because now that definition is used by groups, or can be used by groups to say, such as our compliance department, say, no, clearly social work is called out as a mental health profession, so why should social work be able to provide chronic care management services as part of the healthcare team? That's like a real world example of something we had to troubleshoot at Rush and advocate around. So because of this restrictive definition that limits organizations' abilities to have this workforce, have a revenue source for this workforce, and ultimately it limits access to Medicare beneficiaries for services such as health behavior assessment and intervention services, advanced care planning, other services that Medicare might recognize down the road. To help address a lot of these issues and kind of organize different partners across the field, we have created and continue to lead our Coalition for Social Work and Health. We already called out the historic and leadership role that Chaz at UChicago has played, National Association of Social Workers, CSWE, other players actively working together. We're in the midst of a campaign, as I mentioned, to develop communications materials, but also to train folks, put educational materials out there, and advance policy advocacy, especially legislation we were very excited to have introduced recently by Congressman Danny Davis and Representative Jen Kagan that would address this definitional issue fundamentally, the Integrating Social Workers Across Healthcare Settings Act. We had a wonderful press conference, and we're happy to be on the cover of our Garfield and Lawndale newspaper that some of our community members on the west side get. And are very appreciative of Representative Davis's office support in particular on that. So here we invite you all to help us with this campaign, but also more broadly, shine a light on why social work and healthcare, why social care in general. We've got lots of resources. You all will receive these slides. If you're interested in getting on board with the legislation itself, we have toolkits, social media toolkits, et cetera. And an email here if you'd like your organization to endorse. We'd love to partner with folks in the future as well. And I want to just name some broader opportunities for impact. CMS, I'm showing here on the screen, has what I find to be a nice framework for health equity priorities. And each of these, I think I went through the exercise to think, how could I apply this priority kind of to my own work? And I encourage all of us to kind of think about them from that lens as a call to action for yourself, wherever you are in your own studies or your own work. And invite you to advocate for policies that invest in the things we just made the case for needing, the workforce, programs, and the community level investments, and to do it in a way where you are engaging in research about what you're doing on the ground so we can all learn what's working and how to make it easier, but also engage in practice that's based on research that's been done to date. And do those things in a way that can, again, help us fuel for future policy change and education for future care providers. This is a nice quote from Javier Becerra, our current secretary of HHS, that I'll kind of read and close on as we turn to Q&A. We'll keep making equity and justice our North Star because we know healthcare is about more than just mending bones or dispensing pills. It's about giving people access to peace of mind, to economic security, and to a brighter future. That should belong to everyone, no matter where you come from, what your color, what language you speak. We think all Americans have that opportunity. So with that, we'd love to open up for any reactions, comments, and questions.
The policy that CMS is having for 2024 to like have the new codes. I'm curious if it is just going to be sort of like a reorganization of the funds they already have, or if there's also going to be like an increase, the government is going to increase funding to that.
That's one of the right questions to ask. I believe it's still the same size pot. So no additional infusion of funds explicitly to cover those services.
Yes, please. Go ahead.
I'll deal with the professor.
Thank you so much, Bonnie and Robyn. This is so interesting and such amazing work. It's really, really fun to hear the whole report and everything you're still doing. So thank you for that. I was curious if you recently, Sherry Gleed and Tom Diano had a piece in JAMA. And Robyn, I see you shaking your head, so maybe you saw it. It was really about, not about social work in particular, but about, you know, should we really be integrating social care into healthcare if it's going to be the healthcare system that's really running the show. And I know you guys worry about that a lot. And so I just was curious, you know, when I look at some of the systemic reforms, they're really important for getting things covered, but they don't really get at this problem of who has control, and kind of like social work is sort of subsumed under, you know, other people making decisions. So I just wondered if you have any thoughts about that.
It was such a provocative article. Of course, you would think of that, Colleen. But I, you know, I think it's going to be it's a dilemma if we're going to medicalize social services. Yet, how is it going to get paid for in this super gorilla system of the 800-pound gorilla of CMS, dwarfing the little that goes into the human side of health and human services? So it's a really tough one. Do you have anything to say about that?
Would love to further discuss. I think it feels like, to me, I think healthcare it's really important that healthcare is doing their part. And so it's how do we not make sure that that overshadows. I brought up like the buy versus build, you know, to not get in the road of the short term, we want to build versus buying and investing in other leaders and working towards fundamentally shifting power dynamics.
Is this on? Can't hear anything. Oh, yeah, there it is. Adam Scheffler, a graduate of SSA/Crown. Tom Diana was my advisor, so shout out to him. Very, very great presentations. You know, I wonder though if we're still tinkering with a system that's fundamentally flawed. I mean,
Of course.
you know, what we really need is restructuring of the system according to, you know, first principles, and we're never going to get that. And the other thing is to foreshadow Professor Grogan's presentation. We've got this corporatization, financialization of the services that aren't controlled by CMS, and they're rapidly gaining control over public services as well. So, you know, we're all paying the piper here.
Absolutely. And I hope it didn't feel like our suggestions were Band-Aid approaches. I think we've struggled with what you're saying, both of you, for so long that we just had to dig into something knowing, you know, if we only had global payment, if we could only show the impact of a social service agency on the overall health outcomes, maybe more money would go to all of that. But totally agree, can't disagree. We've just tried to, I hope we haven't put our head in the sand, but I think
I think it's good to name. I mean, certainly doing payer-based initiatives where you have to do something a little bit different because of someone's health insurer is like, it's just not the ideal way to work, nor can it be efficient, I wouldn't think. It's been really exciting seeing public health dollars in recent years. Like for our team, that's meant our social workers and community health workers could serve anyone, patient at Rush or not, family member, you know, oh, my neighbor had this question, can you serve them? Yes, because our goal is to improve the public's health. So definitely recognize that broader need.
going. Oh, no, it's my own, it keeps me up at night.
Yeah, no, it's just, it is a puzzle, which, you know, I mean, I've been grappling with it too, as have, you know, so many people, but I wonder when you're thinking about legislation and like the pilot program in North Carolina, the 1115 waiver. To me, what's quite interesting about that model is it for those of you who don't know about it, the managed care company contracts out with a coalition of social service, you know, like the coalition gets the money and then they distribute to the social care providers.
Right.
And so it just seems really, but I don't think they've gotten a really good contract, right? So that they are able to have leverage.
Yes, this
with the
happens
managed
all
care
the time, right?
organizations. Yeah,
right.
and so it seems like we need to be thinking politically
Right.
about creating coalitions that then maybe have some power in this system.
Yeah.
I don't
And then the
know.
managed care can say they're partnering, they check their box, yet they're not sending any business their way. That's what happens a lot.
But states can build that in to managed care requirements, to contract with certain other funded. So,
Yeah. No, I think there's
That's the
possibilities,
political-
but it's
that's
kind
the
of
Yeah,
lever,
but
right?
it's-
thinking
State
about
level.
what's the leverage,
State
yeah.
level. Uh-oh.
So as you know, social determinants is a very broad basket. I have a friend who believes that this social care ought to be framed as precision social determinants, sort of analogous to precision medicine. Back to your, you know, do we join or fight the medical model? I'd be interested if you sort of accept that premise. And do you see progress in this? You know, it seemed to me some of the Medicare changes have that character, actually. You know, these individual assessments. And so if you could sort of just talk about that, how do we get from these broad, sweeping, rhetorical statements about social determinants to sort of interventions that are tailored and targeted and you can actually pay for.
What's happening? I mean, that's what's amazing, is that it's happening. I mean, the fact that CMS has some of that in there in such a big way, and we've all been allowed to comment on it. I never thought this day would happen. So I absolutely agree with I think we have the same friend who talks about the precision medicine. And it's an interesting concept. It goes back to that person-centered quality. What would you say about that?
I think the way we do that policy-wise is by making sure we have a way to have the workforce that's skilled to do those individual level assessments, and then have a routine way to look at the data to make sure our community level investments through the variety of agencies are kind of aligned with what we're seeing from at the workforce level. But certainly, like in our individual intervention research and anecdotally having our social work care managers do these conversation-led assessments that are really iterated on social work's 100 years of history doing this, but also very much organic and live in the moment based on the person and family in front of them. I guess it feels like leveraging that feels like the way to scale up rather than trying to make that an algorithm, because people are people. So it's always going to be different combinations of the tailored menu items.
I mean, just the scary piece of some of this is some of the sharps that we talked about, the now POWs or whatever. It's really nice we're curating services. It's really nice we're screening for social determinants. But if we don't have the work that goes on that we know best, that being able to engage someone around stuff that's really hard for them to engage around, that it's not going to be effective. And I think that's the piece that we need to hold on to and fight for a bit more.
Great question and that great response. Let's thank our.
Thank you.